Hello, and welcome to the Southeast AIDS Training and Education Center's Clinician Mentoring Program. My name is Brittany Copeland, and I would like to introduce Dr. Alice Thornton. Dr. Thornton is going to speak on ART, Common Toxicities. Dr. Thornton is the Medical Director of the Bluegrass Care Clinic, and she's also the Project Director for the Kentucky AIDS Training and Education Center. Okay, and I'm going to turn it over to Dr. Thornton. Thank you.
Presentation today I did take from the National ATEC website. I was going to redo one, but they had it all laid out there straight from the guidelines, so that's what I am using today. Here's our objectives. As most of you know, people are going to adhere better to their medications if they have less side effects. So it's really important to talk to patients about what the potential side effects are and to also help them anticipate and even treat potential side effects. We always try to give patients a handout on new medications and go over that with them, and I think they do appreciate that. It's better to have that discussion. I just want to make a point of the first point that's on here is that adverse effects or side effects are one of the most common reasons for non-adherence and for switching or starting antiretrovirals. I think as providers, we would never necessarily think of just stopping something as important as your HIV meds ourselves if we were the patient, but our patients often feel that sometimes the side effects are worse than the disease themselves, and so they will go ahead and do that. So again, we need to have the discussions right up front and even tell them, you know, don't stop the meds without calling me, and there are things we can do. So I think that's really important. There are certain groups that might be at higher risk for having side effects. Those actually include women, those with comorbidities or on interacting medications. One of the comorbidities there that I often think of are women that are pregnant, for instance. They already are nauseated, and then we put them on a medication that may worsen that condition of nausea. So again, very important to have these discussions as you start the medications with those patients. So now we're going to, the way this is broken out, and there's a lot of information here, we are not going to cover it all. Brittany has sent you the PowerPoint so you can have it for your reference. But it is broken down into classes of HIV drugs. So the first class are our NucleosideReverse transcriptase. So these are our older drugs. Actually, the lactic acidosis and hepatosteatosis, we really don't see so much anymore. So I'm not going to spend time talking about that, nor am I going to talk so much about lipodystrophy, but it's there and it can occur, especially with those drugs. I do want to, however, take some time to talk about abacavir here. As most of you, I hope, are familiar with, at least now, something called the HLA-B5701. That's a test that you should order before you start this medication. And it's testing for the genetic material that shows that the person would have the hypersensitivity reaction. And so that's what the HSR is. So you do the HLA-B5701 test. If the person is positive, you're not going to put them on abacavir because that is a syndrome that they can get, which includes rash, shortness of breath, fever, a whole syndrome. Obviously, we've talked about rash already. There is some data that I think, I tend to think it's a wash, that it's not necessarily an increased risk of MI, but there is some data out there that, depending on how you interpret it, you might think that abacavir can cause an increase in MI. So that's something to think about. I'm not going to talk about DDI. Going to move on to tenofovir or Viride. And I think this is really important because so many of our medications today have this as a cornerstone to the medication. It's part of many of our once-a-day medications. There are renal impairment issues known as Fanconi syndrome. And I'm not going to spend time about this because one of our presenters today is going to discuss that as well. Also, decrease in bone mineral density. There's a lot of studies, or not a lot, but several studies done that it does seem that there is a decrease in bone mineral density in patients that are on Viride compared to patients that are on other nucleoside reverse transcriptase. So it is a reality that we have to be aware of. Headache, which can be in most any of our HIV drugs, and then GI intolerance in the form of gas or upset stomach. So then moving to the class of non-nucleosides, this is our second oldest class of drugs. And if you think about nevirapine and some of the early drugs, definitely rash was very important, and we had to caution patients about Stevens-Johnson syndrome. Also hepatotoxicity. This hepatotoxicity is seen more in patients with higher CD4s with the nevirapine, so we do avoid nevirapine in people with CD4s greater than 250 or 300 because we do not want to put them at risk of hepatotoxicity. And then because of the certain enzymes that are revved up in using this medication, there are a lot of drug-drug interactions, which is not our talk today. Efavirenz is next up. I kind of call this gaga brain. The person can feel sort of between sleep and wake. And I really spend some time talking to the patient about what is your work schedule. If they are a person that is on that has to get up at 4 a.m. in the morning, they need to be aware that they may feel a little groggy when they take efavirenz at night. So that's a really important discussion. I've had college students no longer want to be on a triplet because they felt like they could not stay awake in class for those early 8 a.m. classes. So it's a very important discussion to have about how that patient is going to do. I tend to think that efavirenz can cause anxiety issues as well as the new Edgerant in that category as well. And so we do have that discussion. If they're a very anxious person, I may not choose efavirenz, or I actually will counsel them, let's think about something different. So that's important. Dyslipidemia was going to come up time and time again. Etravirine, I really don't see that much nausea with it, but it is listed as a potential side effect. Our next is rilpivirine. We've already talked about this a little bit with the depression, insomnia, and that whole anxiety issue there. Moving to the protease inhibitors, you can see a long list. We're not using as many protease inhibitors as we used to, but you do need to be aware of the changes in lipids that you can have. And that is seen with Presisto or darunavir. And there can be GI intolerance. So, and then we know using the Norvir to boost not only affects the protease inhibitor that we have the person on, but can have other side drug interactions. The main thing to remember with our atazanavir is the hyperbilirubinemia that actually does not have a clinical consequence, but you need to be aware of it. Most people, if their bilirubin's getting above 3, do not want to be on the Radtaz anymore because their neighbors, their family has noticed how yellow they are. You do need to be aware about kidney stones with atazanavir as well. Darunavir, my biggest thing that I've run into has been rash and increased LFTs, and that is indeed what was listed here as the main side effects. I'm going to skip over these because we don't use those very much. And then moving to our integrase inhibitors, which we do use quite a bit these days. Dolutegravir, I actually have not had any problems with dolutegravir, but the manufacturer does list headache, insomnia, and rash, hypersensitivity as possible side effects. And then the, oh gosh, I forget, the Stribild, the integrase inhibitor that's in Stribild, sorry, my brain is switching off on how to say that. Egavetegavir does have a decreased creatinine clearance, so you need to be aware of that. It doesn't seem to have clinical significance, but you do need to be aware that that could be changing. There is, however, increased risk of tenofovir or viride-related nephrotoxicity as it is a combination pill. And then, of course, nausea and diarrhea. Most of my patients that are on that say the diarrhea is short-lived. And so if you just caution them about that you may have diarrhea for a few days and then it's going to go away. Most people can tolerate that. Moving to our raltegravir, rash, nausea, headache, diarrhea. I don't see a lot of this. I actually have patients that say they have no side effects whatsoever with it, but you do need to be aware that there can be myopathy and rhabdomyolysis as well as diarrhea. Maraviroc, we don't use very often, but when we do, you do need to be aware that there can be some substantial side effects that are listed here: rash, abdominal pain, upper respiratory tract, cough, hepatotoxicity. I've not had really any problems with it. More concerns that I've had have been the drug-drug interactions. Infuvritide, of course, is the Fusion, and a lot of patients really hate this. It is very difficult to take. people get very painful hardened areas at the injection sites, and so it is something to be aware of. And I really do view this drug, because of its side effects, as a sort of last-ditch effort. This is just to remind you again about what we've already talked about, the lactic acidosis. You do need to be aware of it a little bit more in pregnant women and people with underlying liver disease as well. I think this one I just put in for your benefit. I think we've already really covered this. Nevirapine, as I mentioned, you do want to be aware and not start that in people with higher CD4s, greater than 250 in women, greater than 400 in men. Insulin resistance, really the earlier drugs were more of an issue here in some of the older PIs than now. Sometimes there's some noise about efavirenz. I'm never quite sure what to make of that. In this particular slide deck, which was going straight from the new guidance, it did not talk about that in this particular section anyway, as far as efavirenz. Really should not be seeing this with your newer drugs. Hopefully, if you're seeing lipoatrophy or lipodystrophy, this is because people have previously been on AZT or D4T. If you have patients that you have inherited that are on older regimens that are having lipoatrophy or lipodystrophy, you really need to take them off those older drugs. Sometimes you might see someone that's still on Trisavir, for instance, and they're having facial wasting, or they're having, no butt and no muscles in their legs or whatever. You need to think about switching them to something else and getting rid of that D4T, AZT combination. And then DDI as well. I think we've already sort of touched on this just a little bit. Again, depending on which one you believe or not, as far as whether abacavir has issues with recent MI issues. Another big one that I think, again, I'm not trying to make this a VIREAD talk, but I do think that's one of the more common things that I do see and need to be aware of, and my primary care doctors talk to me a lot about, is the bone mineral density loss with their VIREAD. But we could also see that previously with AZT and D4T as well, and as far as abacavir. And then HIV itself can be associated with that. Some of the people you need to target in on that could be having that problem. Other risk factors would include people already with a low body weight, females, white or Asian ethnicity, older age, alcohol or tobacco use, hypogonadism, vitamin D deficiency, and people that have had steroids. Rash, almost any drug can give you a rash, so you just need to be aware of that. A lot of times we feel like we can work through the efavirenz rash. I typically do not work through a darunavir rash or the other common rashes that you can get. A lot of times I will switch people off Sestiva if they have a rash, but in the instructions with that medication, it does say that if the rash is mild, you can try to work through that, and a lot of times it will go away. I typically tend to be kind of afraid of rashes. I've had patients have TEN and Stevens-Johnson, and so I think you're sort of, you are who you are by your past experiences. And so because I've had some people with really life-threatening rashes, I don't mess around with them very much. But so just be aware. Typically, if a patient calls into us and say they have a rash, I want them to be seen, either myself or the nurse. I want someone to eyeball it. What patients describe as rashes often are very different than what we would call a rash. So I think it's very important to take a look at that and make sure patients know when you're starting them on medication that during this time period, of the first few weeks, first 6 weeks or whatever, you want to hear from them if they're developing rashes so that you can really look at it and make those decisions. We've talked quite a bit about VIREAD already. Just to point out, some of our older drugs, as you can see, the IDV would be the Crixivan, but then don't forget about Reataz can cause some chronic kidney disease, as well as Kaletra, but the biggest thing with Reataz is, remember, you can have kidney stones. And basically what you need to do is to stop that drug. Sometimes we have overlapping toxicities, so peripheral neuropathy, we don't use DDI and D4T anymore, but if you did, you would see that those combinations together definitely have a terrible neuropathy component. Sometimes AZT can have some neuropathy as well. Bone marrow suppression, these are listed here. And then hepatotoxicity, they do list efavirenz here, which is absolutely can happen. And then we've already talked about darunavir as well, can give you a bump in the LFTs. Pancreatitis, not so much our newer drugs. This is really a thing of the past, but Bactrim and pentamidine, if the patient should happen to get that, could be an issue.